Hello, everyone, and welcome to another episode of Healthy Politics, the first one in the new year. We're going to be discussing the eternal intersection of healthcare in the United States and American politics. My name is Nick Carls. I'm the Director of Compliance in the Employee Benefits Department here at Holmes Murphy, and with me is my esteemed co-host, Den Bishop, former president of Holmes Murphy and our longtime strategist extraordinaire. Say hey, Den.
Hello, Nick. How are you?
I'm doing great. We've got a lot to talk about. The government's going to keep us busy, is what it comes down to. We have a lot to do. I'm sure you've been as busy as I have been over the last week or so with the new administration getting sworn in, Trump getting right to work, executive orders, and all sorts of fun stuff flying all over the place. Congressional leaders making pronouncements about what they want to see happening, and so there's a lot of good stuff for us to talk about.
There is. I'll clarify one thing. I know a question that we had from some of last year's is part of what we talk about is what has happened and the impact of that, and part of what we talk about is what is being discussed and might happen. So I think we got a little bit of both to talk about today.
Yeah, and some of the stuff that has already happened is kind of one of those things where I think we just expect it now, right? So when Biden came in after the first Trump presidency, he put a freeze on all pending or proposed rules, final rules that hadn't been published to the final register. Basically, just put a full stop on anything that by law hadn't kind of become a rule, and also pulled back on a bunch of Trump's executive orders. And what do you know? President Trump has done the exact same thing, right? He came in his first week, he did a bunch of executive orders, pausing proposed legislation, not legislation, excuse me, proposed rules and rules that hadn't been published to the Federal Register, and then rolling back a bunch of the Biden administration's executive orders where he could.
Yeah, there's one item on that has hit my radar screen that I don't think we know the answer to, and it was the restriction or removal of medical debt from credit reports, and that was supposed to come into effect. We looked at, actually, you and I were talking about it mid-March, March 17th, I think was the date that's supposed to be effective. No idea how the Trump pronouncements do they impact that? Do they not impact that? You know, we are in a period of high medical inflation and kind of our third year of that, according to our data team, and something like the removal of medical debt from credit reports. That would remove a motivation that some people would have to pay their doctors and hospitals what they're owed. And I think bad debt would go up. And does that ultimately spike inflation a little bit more? Another contributor to inflation. So, there's some good and bad in something like that. Good for the individual that when they're trying to apply for a car loan or a home
Yep.
loan or anything else, the medical debt you have doesn't get counted anymore if this does in fact follow through. Bad a little bit on the healthcare industry of I think outstanding debt will increase significantly. So more to come, whether that's included in the Trump pauses on things or not. It did make the Federal Register, but I don't know what any of that means anymore.
But it's not effective yet. You never go back and forth. It's in the Federal Register, not effective. How does that Trump's executive order play into that one? We'll wait and see. I'm sure we'll get a little bit of guidance on that one because it does have a big impact. So the industry is going to be pushing on that, and it is an interesting. Medical debt is an interesting thing, right? Like if I go out and purchase a car that I can't afford, and then I'm unable to make my car payments, whatever. We look and they go, okay, well, there's some choice there, right? Someone that has a heart attack and they have a $10,000 out of pocket or something like that, you're not choosing to have a heart attack. And for a lot of Americans, $10,000 out of pocket is unaffordable, right? And so, to your point, it's a bit of a yin yang type situation.
Unaffordable and common in current plan designs.
Exactly. I will say one of the executive orders that I did like right off the bat is like, I like this. This is good. And I think a lot of our friends out there, a lot of clients, prospects, other employers will enjoy is the one where they got rid of the notice that plan sponsors and issuers were supposed to provide with hospital indemnity plans, letting everyone know that it was not major medical coverage. And we looked at it, okay, I get where you're going with this. You want people to, not assume that they're getting good medical coverage from this. So you're going to have a notice. But the way that they had it layered in there and worded, we had clients saying, well, wait, where do I have to put this? Do I have to put this in my benefit guide? Do I have to have this in my HRIS system? It was very clumsy and cumbersome. It was one of those things where this could have been tailored a lot better. We could have just said, any carrier that's issuing this has to provide them with that statement and give them a 10-day period to back out if it's something that they don't need, right? That would have been a better approach. So you saw that one get wiped away like this, and it was like, oh, cool. Good. Let's talk about what we're hearing about from some of our legislative leaders, because that's a big part of the conversation right now too. Do you want to go first, or do you want me to go first?
Fire away. I'll follow your lead.
Yeah, Senator Bill Cassidy out of Louisiana saying that PBM reform is at the very top of their list for the Senate Health, Education, Labor, and Pensions Committee, and that's a pretty important one, right? That a lot of the things that we deal with on the benefit side, the HELP Committee, if you will, is what they call themselves, is they're the ones that are kind of in charge of producing the legislation in our field. And the fact that they're saying that that's pretty much top priority would indicate that we're going to see some action here. And as you and I have discussed in the past, and as Nathan has said, PBM reform is popular, right?
Yes, and the spending. I read a report that talked about the public relations and lobbyist spending that the PBM industry is launching right now to try to defend themselves. Apparently, is pretty significant. So if they have upped their spending in the lobbying efforts in the PR way, that means that they feel a threat that that this actually could create some action.
Yeah. And even if they don't completely head it off at the pass, maybe they can water it down a little bit, right? I have a friend that's worked as a lobbyist for a number of years, and one of the things that he always says is, oftentimes we're not trying to bury a bill or anything like that. We're trying to get it watered down to the point that it's palatable, that we can handle it or whatever. And so I wouldn't be surprised if that's part of the approach.
Yeah, when we think about the pharmacy space and prior Trump administration, in his first term, the Biden administration with doing things like the capping the price of insulin, doing things to try to make drug prices more affordable. I do think that the action to try to make prescription drugs more affordable is popular on both a Democratic and a Republican side.
Yeah.
And there aren't very many issues that bring the two together, but I do think that that's one. And if they can find a pathway, whether it's with PBMs or something else, it seems like PBMs are probably the easiest targets. They don't manufacture. There's no R&D in a pharmacy benefit manager. They're just part of the distribution channel. And I do think because of that, they're a likely target. So
Yeah.
I'm not shocked.
Well, it was back in May of 2022 where the HELP Committee voted 18-3 to approve the Pharmacy Benefit Manager Reform Act. It didn't go anywhere after that, but they came up with a full piece of legislation involving rebates and how those have to be passed along and stuff like that. So they already have the framework ready to go. Another piece of legislation where they already have the framework set up is one that's just been reintroduced by Representative Jeff Van Drew out of New Jersey. And he's talking about prohibiting a group health plan from imposing any prior authorization requirement, any utilization management technique, or any medical necessity review for any item or service for which the benefit is covered by under the plan. I saw that one. You talk about the goal being to control healthcare spend. Den, do you think that would increase or decrease healthcare spend if that provision was ever enacted?
It would skyrocket healthcare spend. And it's not because I believe that a lot of those programs are massively effective. I don't. I mean, they're kind of a necessary part, but I do believe in looking at data over the years, industry-wide, in our entire book of business, in kind of internal and external data, that high quality healthcare is actually the lowest cost healthcare,
Hmm.
which seems really weird on the surface because everything else we buy, if it costs more, it's better. And I tell you, where the lowest quality surgery that a person can have is a surgery that wasn't necessary. You're
Sure.
taking all the health risk for something that's not going to deliver the benefit. And there's a meaningful difference between the highest quality providers and the tests and the procedures they do and don't do, and the lowest quality. And if you remove all of those filters from the system, then it does open the door to a place that I believe costs would rise. I think that's going to be really, really, really hard for anybody to get enacted, but it will be popular because nobody likes an insurance company saying no to what a doctor or hospital recommends. So I get the public side of it. I get that.
Yep.
If we could find a way to better empower providers on that to make those decisions in a more user friendly way, I think there may be some gold inside of that. But simply having something that said, hey, anything that gets desired to do or recommended by a doctor or hospital has to go through with no review would be a real challenge.
There's a practical component to it, and you actually brought up a really good point. This didn't make it out of committee the last time it was introduced. I think that one of the reasons why it gained a little more traction, a little more news coverage this time, is just because of what happened in New York with the United CEO, right? And that really put the spotlight on prior authorizations, on the denials and things like that. So I do think that's where that's coming from a practical standpoint, what I do on a day-to-day basis, I look and I go, then how would a plan participant ever know whether or not the benefit was covered outside of having an extremely comprehensive SPD, summary plan description, that listed out every single thing. And then employers would have to make sure that every single employee got that yellow book sized packet of information, and they would have to go through that and look for the code probably to see if it was going to be covered by the plan, because these are the things that we use, right, to keep folks from just, as you're pointing out, going in, doctor says do it, you do it, and it turns out that no, your plan, which has the right to design itself in a way that it's not covered, won't cover it, right?
I'll give you a simple, practical way that we can make this whole thing better. That wouldn't even require legislation.
Sure.
The major payers all know the practice patterns of the providers. They have the data that says when someone shows up with this, this is what happens. They know that. What if we had a market movement that said, hey, the top 50% highest quality providers, if you go to those, we will eliminate all of these restrictions, referrals. That
Sure.
if you go to one of the 50% or 60%, or pick a number, I think the market can create products and services to deal with this issue and remove the administrative burden and still get to the highest quality. And the lower quality providers that have poorer outcomes, they have more errors, more unnecessary procedures, maybe they still have to do this, but we open the door wider for that. I think there are market-based ways to do this that could solve some of these problems.
I really like that idea. And I mean, it would be a pretty big task, but it wouldn't be that hard to come up with a framework for reviewing, medical necessity, right? Okay, we're going to review these 10,000 claims, and would we have said that this is medically necessary? And then you'd look at some of the providers and say, half of yours were not medically necessary. You're not in. That's an interesting. I like that approach.
Let me walk you down a step, and we'll go at kind of a different place. If we think of anything where AI makes sense, it's in med.
Yeah,
And so with the potential of AI, you could take every single lab test that's done on anybody in America, and it runs it through, and it says, based on this, here's everybody else who's ever had this outcome of a lab test and what it said it was. And every other scan that's ever been done, it's this and that. AI can really be a place where I think you're going to see in the future, and not too far away, that there get to be AI driven approvals and not approvals based on big data, and every person who's ever had this result before. This is what it was. So this is what we do. I think we're headed to that kind of place, and I think you could see some regulatory environment come up on the utilization of AI in healthcare, and that be with assuming that Robert Kennedy gets approved as the Secretary of Health and Human Services. I think that comes up on the table during his 4-year reign. I think it's coming quickly.
And I do think that as you're saying, there's a lot of opportunity there.
Mm-hmm.
As we know in our field, data's king, right? And
Right.
if you have that type of processing ability where we're able to just in real time get that information, that'd be a game changer, no doubt about it.
As a patient, I would feel better.
Yeah.
I mean, just all of a sudden, every MRI that's ever been done has access to that, and every MRI when mine looks like this is what it is on. I mean, it's like great, then at least we know. It just so I think we're going to get to some advancements, but there will have to be some rules of the road.
Yeah.
Because you're going to have the insurance companies, the payers, trying to build and integrate some of these things, and what's in bounds, what's out of bounds. I think it'll be a fascinating thing. And I do also believe that on the backside of it, if done right, that we can get to better medical outcomes, help people get better faster, save lives. Kind of cool what we'd all like to do. And I do think it's odd. We all refer to it as the practice of medicine. Maybe with some AI, we could move beyond practice and get in the game.
I
Just a
like this.
thought.
I actually feel inspired, and so I say we call it for today's conversation. That felt good. That's something I'm going to walk out of the office today. I'm like, I like that. I like that. I'm feeling good about things after that one. So, Den, if it's all right with you, I say we call it for the day, and you,
We'll have plenty more to talk about in terms of this administration's stated goal that they have to lower the cost of healthcare. So just like they've said they want to lower groceries and oil and gas prices, and
yep.
they've stated they want to lower the cost of healthcare. I think in a future episode we need to talk about what might that really mean, because healthcare inflation right now is still high. It has not come down yet, and there are no signals saying healthcare inflation is coming down.
And I'm willing to bet that by the time we get around to our next recording, you and I are going to have some interesting new topics to discuss. Based on what we've seen in the first week, I think the next 3 will provide us with plenty of fodder. So it should be good. And as we always say, it doesn't have to be the end of the conversation. If you found anything interesting about this or you have additional questions, reach out to your Holmes Murphy representative. They know how to get in touch with us, and we can continue to discuss this stuff. Otherwise, we will catch you for the next episode. Thank you, everyone.